just want to thank everybody, whether you're watching the recording or with us live today, for the Motivity Care webinar series. And we are delighted to have with us Dr. Gerda Maisel. She's the founder of MyMD Advisor. She's a board-certified physical medicine and rehabilitation physician, and she has over 10 plus years of experience as a chief medical officer. But also, like many of us, she has also been a caregiver to her mother. Her clients are often in the hospital or in rehabilitation after an accident or a stroke or other serious illness. And she provides the expert medical navigation and patient advocacy that you need for a better outcome when you need the real medical advice. So we are delighted to have you with us, Dr. Maisel. Thank you for sharing your time today.
Thanks, Mim. Great to be here.
Well, I know there's been a lot of changes over the past few decades, and we know that patients are getting pushed out of hospitals at a much faster rate than they used to. Why is that happening?
Well, it comes down to money. So some people may assume that every day that you're in the hospital gets more money, which is called a per diem style payment. But the way that it actually works is that hospitals get a case rate. So they get a fixed amount of money no matter how long a person is there. So it's based on the diagnoses, and let's just say the diagnoses bundle says you should be there 5 days. Well, if you're there 15 days, the hospital still gets the same money as they would get for 5 days. So hospitals need to turn over the beds. Think of a restaurant that has to turn over their tables in order to make money on each new customer. Well, a hospital has to turn over their beds because they need a new case rate in that bed generating revenue.
That's kind of scary to hear, honestly. When you think about that patient being more of a commodity than a human being, but clearly something that we have to be aware of if we've got a loved one that's in that hospital bed. So now that we know what some of that challenge is, I know your expertise in this area. What are some of the tactics that a hospital case manager or discharge planner may be using to try and push you or your loved one out of that hospital?
Well, yeah, I mean, the case manager, that role didn't even exist. I'll really date myself 30 years ago.
Hmm.
When they first came in, the case managers were there to just try to help very complicated people. Now, case managers help everybody get out of the hospital in a timely way. And, the tactics vary widely by the personality of the case managers. The good ones, listen carefully, understand the issues, the social situation, the family, and the patient's preferences. The ones who have a strong agenda will say, oh, you're going to be discharged tomorrow. Where are you going to go? And then they will hand you a list of rehab facilities and say, you need to pick one, and I need to know in an hour. Well, you are allowed to take some time to look over the list. They're not allowed to recommend. But what you really want to do is know that this is coming. And ideally, think about and ask, first of all, what's the level of care? And we can talk about that a little bit more. But also start to ask around in your area as to where your loved one might go. If there's a particular subacute, let's say they're going to go to a subacute rehab. And so then when the case manager comes to you, you either need to say, I need a day to look into places, or you can say you're ready and say, here's my list of a couple of places. Now, one of the things I'd like to warn people about, and I've seen many clients get caught in this, if they don't realize it, the case manager may say, oh, okay, you want to go to Joe's nursing home? Well, what about, can we apply to Bill's nursing home too, just in case? And you don't know anything about Bill's nursing home. Well, if you say, sure, you can apply to Bill's just in case, if you do a little research and it turns out that you don't want your mom going to Bill's nursing home, if you've already said to the case manager, sure, you can apply there just in case, then she's got to go if that's the only place that takes her.
Right.
So
And I
don't allow the just in case applications. Make sure that every place that you give permission for, you know about and you're sure it's a reasonable place.
Right. And I think that gets a little bit deeper. It is some of the things that we've done at Motivity Care because, again, there are a lot of questions that you want to ask when you're vetting these facilities. Are they really going to give you the real staffing to patient ratio? Like, do you really know if they're both semi-private, private? Do you know if it's both short and long term? So if they only have short term and you have an additional issue, are you going to have to move that person? Um, what we've seen too is that some of them, only depending on your insurance, only take a certain percentage of their patients that have that type of insurance. So it can get very complex and overwhelming. And again, knowing what to ask or having that support, I think, is really critical, especially when you're in an emotional situation. So you're right. Then those lists, as we all know, are 30, 40 different facilities. Even the basics of knowing how far away they are from the primary people that are potentially going to be visiting that person is just something to take into consideration to keep the stress level down. But subacute versus acute, I think maybe just if you'd explain a little bit to the audience about what that really means would be, I think, helpful.
Sure. Well, there are multiple levels of facility-based rehab care. And those levels are inpatient rehab, which is also called acute rehab, which is also called IRF or IRF. Inpatient rehab, IRF, acute rehab, all the same thing. IRF just stands for inpatient rehab facility.
Hmm.
And then there's subacute, which is sometimes called SA, sometimes called SAR, sometimes called SAR, all subacute rehab. Sometimes you will also hear it called nursing home rehab. But if it is referred to as nursing home rehab, you want to make sure it's in the short stay area. And there is one other level that I'll mention. In New York, we have very few of these, but there's a bunch in northern New Jersey, and that level is called LTAC, which is long-term acute care hospital. It can be a unit, often it's freestanding. And LTACs are places where people who have long-term hospital needs can go for a month or two. Often these are very, very sick people on ventilators or, perhaps they need dialysis and they're not ready to go home, but they don't need all the bells and whistles of a regular acute care hospital. And so sometimes for somebody who's really sick, LTAC can be a good option. And
Good.
then you want me to talk about the care, the sort of the expertise differences?
Absolutely. I think that's really important for people to understand.
Okay, so in acute rehab, that's where you have the deepest knowledge of neuro conditions. So spinal cord injury, head injury, stroke. If possible, acute rehab makes a huge difference. You will have specially trained physicians, specially trained therapists, nurses, etc. And in the past, all facility-based rehab was inpatient rehab. But those days, it could be months after, say, a spinal cord injury, are now down to a month and a half at most, sometimes weeks. But there is a lot of expertise there. But the drawback or is having to qualify to get in. So in acute rehab, you need to be able to be sick enough to need a facility, and you need to be able to tolerate and benefit from 3 hours or more of therapy a day. It doesn't have to be PT, OT, and speech. It could be 2 PT and 1 OT, but generally it's PT, OT, and speech. And so what that means is many older people simply can't benefit or participate in that amount of therapy a day. So most people who go to rehab go to subacute rehab or SAR. And subacute rehab is in a nursing home, but it should be a separate unit. I far prefer a separate unit as opposed to, our long-term care beds, and we mix in short stay. And the reason for that is you want the nursing expertise that is used to dealing with people who are post-hospitalization, because the medical assessment skills are different when somebody's come right out of the hospital versus someone's been living in a nursing home for 4 years. So subacute rehab is where most folks go. You have less specialty expertise in terms of things like head injury, sometimes in stroke or other neurologic conditions, sometimes less in cardiac. but you do generally have better expertise in dementia care and in the medical issues and problems that happen when somebody is a senior. So it's pros and cons. The stays in subacute, if you have traditional Medicare and you qualify, can be over 3 months, which can be really, really helpful as somebody recovers. But if you have a managed Medicare plan, those stays can be much, much shorter.
Mm.
And then LTAC is the long-term acute care hospital. Usually it's people on vents. They got very busy during COVID. And those stays are usually about a month.
Got it. Yeah, very, very, very interesting. Um, in terms of just kind of understanding those pieces. And I think you can start to see, right? You know this inside and out, but for somebody brand new, and it may sound basic, PT, physical therapy, OT,
Oh, I'm
occupational
sorry.
therapy. No, 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 it's okay. I know we all do this, right? When you're in it's totally fine, but I just want to make sure in case anybody wasn't clear about what what that actually is. Um, so it really gets to, the complexity, right, of understanding the medical condition, the specific needs for you or your loved one, and really having a deep dive and understanding what potential options are if you're being moved into some kind of care facility out of a hospital stay. Um, Beyond that, are there any other specific questions? Like if somebody is calling these places, are there like the three top questions you want to ask one of these facilities? Would
Well,
probably be
and
helpful.
before I say go into that, which I'm happy to do, one thing that I want to mention to people that they're not always aware of is that the level of care is almost always determined by a PT evaluation in the hospital. There might also be an OT evaluation. And I often see families say, oh, it's great. PT is going to treat my mom, my dad, my spouse. And then they get mad when the PT doesn't come back. Well, in the hospital, that PT is mostly not there to treat. They're mostly there to document the functional level. Can they roll over by themselves? Can they sit up by themselves? Can they stand up? Can they walk? And document what that functional level is, and then make a recommendation as to the next best level of care. Keep in mind that even when they make a recommendation, you can disagree with it. So if they say subacute and you really think your loved one in the 3 days since that PT came by, your loved one is now doing a lot better, you can ask for a reevaluation. You can also ask to have the care manager apply to a couple of other, to a different level. They may or may not do it, but you can still ask for it because there is more specialized expertise in acute rehab, but you have to be realistic. Your loved one's got to be able to tolerate it for an acute rehab to take them.
Right. Is it helpful to the RNs that are potentially taking care of your loved one in the hospital to have them advocate to, to their
Sometimes
colleagues? Is that a
the RNs that are taking care of you in the hospital are generally so busy doing the things they have to do. They don't, I mean, an experienced RN will have some sense when something's really going off the wall. And where I found RN advocacy the most useful is when the doctor comes in and says, oh, you can go home. And it's not a safe discharge. When home is a problem, there's nobody there. Maybe you're a solo ager. Maybe it's, takes a flight of stairs to get in and then there's nobody to get you out. There may be a variety of situations. And then sometimes talking to that RN with whom you've made a relationship and then having him or her advocate for you saying, it's really not going to be safe to discharge MIM to home, we need to look at something else. So I've seen RNs get involved with things like that.
okay? I think it's really good. We're always about the team around you versus you standing there trying to fight for yourself and may not have the right language or the right relationship. So I think it's really interesting to think about it through that perspective. Who can be your advocate? Um, in that situation. And, again, when we talk about it, it's PT, it's OT, like all these things, terminology is just, rolls off our tongue. But for somebody who's new to this, right, first time they've ever gone through this kind of care situation, it can be intimidating or frustrating if you don't have or feel like you have the right language. So I think, again, having the right kind of support system around you, the right kind of coach, and it really is that your advocate, your coach standing next to you that has that expertise, can help give you a little bit more confidence, I think, in having some of those conversations if they're needed.
Yes, and to get back to your question of things to look for, a couple things that I suggest people do. One is to go onto Medicare if they're going to do it themselves. If if it'd be great if you use a Motivity or something like Motivity, but if you're going to try to do it yourself, go on to Medicare.gov. The way that I get to the right part of it is I go to Nursing Home Compare, and I type in Nursing Home Compare, and then I look for the part on the search which takes you to Medicare.gov. You can search every nursing home that does subacute in the country. You can also look at inpatient rehabs and other things there too. But most people are using it because there's so many choices. A person might have 20 subacutes within a reasonable geographic area. And from there, you can take a look not only at the top level rating, which is the stars on a scale of 1 to 5, but you can drill down. It's got subsections on the first set of subsections is on health inspections, staffing, and quality. And then under quality, you want to make sure you go into to the short stay, and then you can then drill in further. They have a whole bunch of set of outcomes. You can look and you can see, which things matter to you. So in some cases, staffing may be the most important thing to you. In other cases, not returning to the emergency room and seeing really good statistics around that may matter to you. In some cases, you may say, gee, what matters to me the most is the ability to go home. And you can see there are statistics on that. And the one thing I'll tell you about looking at that kind of data, if you're a data person and want to see it, is look at it as directional, meaning don't compare something that's a 5-star to another 5-star and 2 minutes difference in the care, the staffing care numbers. They're going to both be similar. What you really want to look at is the 1 stars versus the 5 stars. And a place that is rated overall 1 or 2 stars, you want to have some really good personal recommendations before you take them too seriously. But likewise, I just actually have a client right now who went to a facility rated 5 stars and she wasn't happy. She did not feel that the nursing care was as good as it should be. And now she's going to go someplace else. So 5 stars is no guarantee that something's fantastic, but you have a better chance of a good outcome with a 5-star rating versus a 1-star rating.
Sure. Yeah. If you see a lot of 1-star ratings, I would, just like any other rating system, right?
Exactly.
Right.
And it's the data is also, it's not immediately current. So, it might say they have 42 minutes on average of LPN coverage, but that could have been months ago and maybe it's better or worse now. So you've got to just look at it as directional.
Yeah, I think that's very, very, very helpful. One of the things I know probably, both through our network and yours, there are folks that we can tap into where it is more recent care and like, well, what is your patients, or the people that you've been working with, what has their experience been in the past month, right? So that kind of can help influence what you're doing. And we recognize that a lot of folks, if you're not in this industry, you probably don't talk to those kinds of people on a regular basis. But it's just another way to get to them. I think also you mentioned, and we kind of touched on this, when you are coming out of the hospital, it's not always about going into a facility. So I think one of the other challenges that we often get into is putting somebody back into their home. What do we need to think about? What does that look like? What are some of the major things we can do or be prepared for to make sure that it's a successful transition back into the home?
So I'll answer that on a couple of levels. In the medical bucket, because I sometimes get people who want to bring a loved one home or themselves go home when they have some medical needs. And from a medical point of view, You have to remember that if you are ill, a doctor is not going to show up at your bedside unless you have contracted with a concierge doc who will make house calls to your place. There are, by the way, and I don't want to go too far afield, but there are in a few areas, there are some urgent care services that will come to you. But you have to be in an urban area to get that, and most people can't access that. The other big drawback medically about going straight home is labs and x-rays. They are, you have to go someplace else. It doesn't come to you. Then there's the big bucket of what I'll call hands-on caregiving. When the person goes home, they are going to be tired, and they need someone to shop, to do the housework, to perhaps assist them to the bathroom, perhaps prepare the meals, to do housekeeping. There are many basic tasks that need to be done when somebody goes home. And then there's that next level down, which is just basic safety. You want to make sure that the house is safe. That if the person recently fell and tripped over a rug, well, you want to make sure that rug's not there anymore. And often people need to hire help at this stage. When somebody goes home, especially if they're going home on their own, it is, in my experience, very hard to do without either having friends or family there or hiring a service or both.
Yeah, I think it's interesting because again, I think the inclination, and I'm going to say it, if you are the primary caregiver, a lot of times it's the wife, the daughter, the sister. They're great male caregivers out there too. We don't want to, negate that, but it brings up an interesting issue because, if you are not a trained professional and catching someone, turning someone, the weight issue, um, this is something we often don't think about. What physical risk are we putting ourselves in if we think we can handle all of this? You're 5'3" and your loved one is 6'2", as an example, and weighs a lot more than you. If that person starts to fall, are you really going to be able to catch them in that situation? Are you trained to even understand what that looks like? And we want to be there. I mean, I think there are a lot of people that feel like this is my job, I need to do this. But understanding what risks you may be taking by doing that without having real trained support around you is something everybody should be aware of. And that's hard, right? But then there's the financial piece of it too. And even thinking about things like, if there is a blackout, for example, and you have refrigerated medication, or you have some kind of medical equipment in the home, whatever that may be, is the electrical system or your wiring, basic wiring, up to speed to handle it? And these are things that people don't necessarily think about, right? When they're coming out. You don't want an electrical fire, of course, in the middle of a care situation. These are kinds of things, again, that having somebody in an emotional situation. And I think that's the other thing, Dr. Maisel, when you are caring for somebody, you're going through that's an emotional journey. It is, and some people are more resilient, some people can deal with it, but having some kind of advice and support around you that is a step removed from that can be a little bit more logical, can be incredibly helpful.
Absolutely.
Yeah. So, what are some of the things that, so say somebody comes home and what are I'm always about three things, right? It's always easier if you can say, like, if somebody is going to be moving home, from your perspective, what are the three things that you should, that are most important to be thinking about?
Well, safety is top of the list. That would be one of the key things that I would think about. And of course, by the way, and we sort of alluded to this, but if somebody's in the hospital and going home is not going to be safe, you can push back on that. You can actually appeal to Medicare or your insurance company if you think the discharge is not a safe discharge. And then in terms of going home, You may need to hire an agency, you may need to hire a geriatric care manager, you may need to hire direct caregivers. This group probably knows, but Medicare does not magically provide aides to take care of you 24/7 when you go home. If you're
Right.
lucky, the person from Medicare, the nurse will come a day or two later. After you get home, they'll see you for an hour, but they're not taking care of you. That need to have somebody take care of you, bring you your soup, do the shopping, all those things we talked about is very important. And an agency or a geriatric care manager can help make sure that those things are in place. Or if you organize it yourself, you want to make sure that you understand the difference between a companion who can't really do hands-on care
Right.
and an aide who, if you need help in the bathroom or a shower, can do that. And those lines between the two are not black and white, they're gray. But there are different direct hire agencies out there, some of whom only supply non-medical companions. And so you need to know enough if you're going to direct hire to hire the right people. Otherwise, you need Motivity, or you need a geriatric care manager, or even a patient advocate like myself.
Right. Yeah. And I think you bring up a really good point because it's something that we talk about a lot about bringing people into your home. How well vetted are they? Right. And my neighbor said you should bring in this person. We've definitely seen this. But I think what people don't understand is when you hire directly, you are now the employer. You are the employer. So that means liability. That aide comes into your home and trips and falls and breaks their leg. You are liable for that. That's why working with good agencies or really understanding the not just that, it's the risk factor, but also understanding like even the insurance piece of that, which I think again, most people do not think about. They're looking at cost only per hour. If that person steals from you, and we hope it never happens, but again,
Oh, it happens. It's happened
it
to a couple of my clients over time.
exactly. And so, how well vetted are they? What is the security behind those people coming in? But you also brought up another thing, and this is something that we do a lot of discussion with our clients about basic security cameras. An electronic door lock that they can use from their phone so that they can be very careful about who comes in and who comes out of that house. If that person is truly a solo ager, meaning they do not have a spouse, they don't have siblings or children near them, that becomes like a whole different set of circumstances, in terms of how you're going to put a care plan around them. And I just want to acknowledge that Kathy Bowers, who is a patient advocate of many, many years, um, talked about like, Office of Aging in your area. There are sometimes resources that they can help you with. But again, it's helpful to know people who know them well because they are also overwhelmed. And so it becomes this ecosystem around you. We are actually at time. And what a tremendously educational conversation. Thank you so much, Dr. Mizell,
Oh, my
for
pleasure.
everything you've shared. Whether you're caring for somebody now or you're planning ahead, we are big advocates of having a care plan for you, for your loved ones. Always better if you have a little bit of a plan before you get into these situations, but obviously, there are resources to help you if you don't. Um, we want to make sure that aging is easier, caregiving is simplified, you are more secure. So if you are going through one of these situations, and want some guidance, advice, getting to the right resource, call us. We are happy to talk to you, get you connected to Dr. Maisel if that is the right resource for you in your situation. And we invite you to join us next month. We are going to be having a webinar focused on emergency preparedness. So if you think about the LA fires, floods, caregiving through a real crisis like that is another piece of the puzzle. Our speaker is Dr. Rita Stafford, global leader, founder of Thriving Edge Consulting. We encourage you to sign up. And we want to thank you for spending time with us today. If you have a topic that you would like us to highlight, please let us know. We are truly honored to have such an incredible network. Obviously, you see the level of expertise that Dr. Maisel brings to the table, and we are honored that she was willing to spend her time with us today. So thank you again. We hope everybody has a wonderful day. And if you are caregiving and you need support, we're here to help.